Okay, so welcome to scientific session number 6. This is the last scientific session in our resident competition. Before we begin, we have a distinguished moderator for the session, and so it's my distinct honor to welcome to scientific session 6, which is featuring papers 21 to 25, Dr. Sareh Parangi, who is our distinguished moderator. Dr. Parangi is the chair of surgery at Newton Wellesley Hospital and director of the MGH Thyroid Cancer Research Laboratory. She's also a past AAES treasurer, and so we want to welcome you to the podium, Dr. Parangi.
Thank you, Anthony, for that kind introduction. Hopefully everyone's had lunch and we're ready to go. Dr. James and I are distinguished moderators together. We decided to send a message together. So I wanted to just talk a little bit about the NIH and the NIH's efforts around diversity, equity, and inclusion, as well as accessibility. So this is really actually nice reading. If you get a chance, it's available on the web for the efforts and strategic vision that the NIH has from 2023 to 2027. And a big part of their effort is around transparency and making data available to us as researchers and as the public. Most countries really would die for having the NIH, so I think we should be really, really proud of the NIH as an organization. They fund over $40 billion of extramural funding, in addition to, of course, the intramural funding, which we're familiar with. So just going over some of the data that they do publish, and if anyone wants, there's a guy called Dr. Lauer. You can look him up, and all the stuff I'm showing today is mostly from him. He's at the NIH. So this is the level of R01 funding that the NIH gives by race, and you can see that the pink line are whites. And then you can see that in general, the lowest level down there are African Americans at the bottom. And you can see that if you go by years in terms of funding rates, we have seen an increase in funding rate percentages in all areas, but that there definitely has been some progress in if you look at Hispanic and Black population of PIs who are applying and getting funded, but overall, Black scientists are still less likely to be funded, with the effect size decreasing by approximately 40% after adjusting for all possible variables. If you look at the K applicants as well, the picture is very similar overall. There are very few Black and Hispanic applicants, even though the rates are steadily increasing with time. And especially in the last 3 years, there's been some increase, and you can see that the blue on the right is the number of funded Black K applicants in this country, and the red are the unfunded. But you can see that the percentage of funded is increasing, but that the total number, unfortunately, of Black and Hispanic applicants in the K series remains very low. This is very pertinent to much of the research that we've heard emphasized at this meeting, which if you look at the very highest percent awarded rates is eye disease, that's EI. They do very, very well. And the percent with the least amount of funding is the minority health and disparities area of research, which receives, unfortunately, the highest portion of African and American Black PIs apply for grants in this area, 16% total. So the least amount of funding, and yet the highest area of interest in research from Black and African American PIs. The data also has PIs who have disabilities, so it's important to look at that as well. And in 2022, only 1.3% of investigators declared that they had a disability. That was a total of about 750 people out of 56,000 applicants. Now, we know that that is not the rate of disability in the United States, so we know that many are not willing to either declare a disability or just don't fill that part of the form out. We also see that the NIH is now publishing allegations of grant fraud, harassment, foreign interference, peer review interference, and research misconduct. And as we know, sexual harassment has been something that they have taken money back from institutions after sexual harassment has been reported by a PI. And as you can see, that's the yellow bar, for example, and there were almost no reports of that prior to 2017. So since the NIH declared that they will actually ask for money back from institutions, there's been a much higher increase of reporting in the anonymous system. This unfortunately doesn't project well, but it's a paper by Dr. Martha Zeiger, which looks at the total number of grants given to endocrine surgery topics. In the green on one side, you see if they looked at all of the grants given by the NIH. There are basically under 20 grants given for endocrine surgeons and endocrine surgery topics. And if you look at it a different way and you look at investigators who are endocrine surgeons, it's about the same number. So bottom line is, we as a society have an opportunity now. The director of the NCI is a surgeon, Dr. Monica Bertagnoli. We have a director of clinical cancer research at the NCI, Dr. Martha Zeiger. We have the president of the ASA, is a long-standing surgeon scientist, Dr. Ron Weigel, a lot of power in this group. The president of the ATA, Julianne Sosa, another surgeon scientist, and the president of the Association of Women Surgeons, Dr. Mary Beth Hughes. We have a lot of power right now to help our cause to increase endocrine surgery research through efforts of cooperating with the NIH. And I think this is the time. This is just one example of the kind of powerful work that's being done. Dr. Zeiger has started the NCI Early Stage Surgeon Scientist Program. And I put a quote from her, where surgeon investigators who will change the world are created. That's just one example of the kind of work that when we put our mind together and the societies together and the kind of leadership power we have at this moment in time, that we can work together to further the science. I did want to just put in one little plug for Dr. Oliver Cope, just kind of for everyone here to remember that good science will always be rewarded, and the opposite, maybe not good science, will not be rewarded. So in 1984, this is a letter I found in the Harvard Library Archives, was a letter from this organization, which was all of 3 years old, to Dr. Oliver Cope, telling him that he was going to be the first awardee of the Meritorious Award, which we now see is named after him, and Dr. Shaha won it this year. And in 1988, he sent an abstract in saying that Graves' disease was a psychiatric disorder, and his abstract was rejected. So just a lesson for all of us. And just a reminder that Orlo is looking over all of us and all the people who are going to be presenting today. So we'll have the first speaker up.
Thanks so much, Dr. Parangi. And just to clarify, you are our distinguished moderator, not both of us. Our first presenter, I definitely do not deserve that title, but thank you. First presenter is Kyla Wright with senior author Carolyn Sieb, Disparities in Access to High-Volume Parathyroid Surgeons in the United States, a Call to Action.
Hi everyone, my name is Kyla Wright. I'm a fourth-year medical student at NYU, and today I'm going to be discussing disparities in access to high-volume parathyroid surgeons in the United States, which is a project that I was fortunate to be a part of under the mentorship of Dr. Carolyn Sieb at Stanford and Dr. Insoo at NYU. Here are our disclosures. So as you all know, hyperparathyroidism is a common disorder characterized by overproduction of parathyroid hormone by one or more parathyroid glands. Primary hyperparathyroidism is the most common form and is frequently marked by hypercalcemia and an elevated PTH, which results in deleterious effects on the neurocognitive, cardiovascular, gastrointestinal, renal, and musculoskeletal systems. Definitive management is with parathyroidectomy, which results in reduced risk of adverse events and improved patient quality of life. Cure following parathyroidectomy is achieved in over 95% of patients with sporadic primary hyperparathyroidism when performed by an experienced parathyroid surgeon. However, operative surgeon volume is associated with outcomes with lower cure rates and greater rates of complication among low-volume surgeons. Disparities in access to high-volume surgeons have been reported for a number of surgical procedures within the literature, which may impede patient access to high-quality care. However, disparities in access to high-volume parathyroid surgeons in the U.S. is limited. So the objectives of our study were to, 1, use Medicare provider utilization and payment data to identify high-volume parathyroid surgeons in the U.S. and evaluate their geographic distribution, and 2, evaluate disparities in access to a high-volume parathyroid surgeon based on neighborhood disadvantage. To identify high-volume parathyroid surgeons in the U.S., we used the 2019 CMS provider utilization and payment data, which is a publicly available data set that includes information regarding the number and type of procedures performed by providers for fee-for-service beneficiaries. We searched this data set using the CPT codes corresponding to parathyroidectomy and reoperative parathyroidectomy, and we defined high-volume parathyroid surgeons as those who performed greater than 10 parathyroidectomies for fee-for-service beneficiaries in the year 2019. Given that Medicare beneficiaries represent approximately a third of payers for a typical surgeon that performs endocrine operations, we estimated that most of these surgeons were actually performing greater than 30 parathyroidectomies per year. Next, we got our geographic and population data from the American Community Survey, which we substratified by Metropolitan Statistical Area, or MSA, which is a geographic region that's defined as a urban core with any surrounding counties with socioeconomic ties. And then we assign each high-volume parathyroid surgeon to their appropriate MSA based on zip code. Next, we evaluated the distribution of the high-volume parathyroid surgeons to fee-for-service beneficiaries across the U.S. And to do this, we calculated the number of high-volume parathyroid surgeons and the number of parathyroidectomies performed relative to the number of fee-for-service beneficiaries in each MSA with a population greater than 1 million. Next, to evaluate the distribution of parathyroidectomies performed by high-volume parathyroid surgeons, we used the Gini coefficient to calculate any inequality in the distribution of high-volume parathyroid surgeons and the number of parathyroidectomies performed. And then next, we evaluated the distance to high-volume parathyroid surgeons based on neighborhood disadvantage. So to do this, we looked at each neighborhood and calculated the distance to the nearest high-volume parathyroid surgeon, and then we compared the distance to the most proximal high-volume parathyroid surgeon between the advantage and disadvantaged neighborhoods. And we compared this using one-way ANOVA and Bonferroni corrected pairwise comparisons. So in total, we identified 445 surgeons that met criteria for a high-volume parathyroid surgeon and were included in our study. And as you can see, 71% of surgeons were male, and surgeons were most commonly located in the South. Here you can see the distribution of high-volume parathyroid surgeons relative to the number of fee-for-service beneficiaries in each MSA with a population greater than 1 million. And this number was highest in Salt Lake City, Utah, followed by Birmingham, Alabama, and Memphis, Tennessee. Here you can see the geographic location. Sorry, is this kind of working? Okay, here you can see the geographic location of the number of high-volume parathyroid surgeons per zip code and the number of parathyroid surgeries performed per state based on the shade of blue, with darker colors indicating greater number of parathyroidectomies performed. And as you can see, the total number of parathyroidectomies, both overall and relative to the number of fee-for-service beneficiaries, was highest in Florida. Here you can see the relationship between the number of high-volume parathyroid surgeons and the parathyroidectomies performed. And we found that 50% of surgeries were performed by only 20% of high-volume parathyroid surgeons. And the associated Gini coefficient was 0.41. Where a Gini coefficient of 0 would have indicated perfect equality in the distribution, a Gini coefficient of 0.41 indicates significant inequality in the distribution of high-volume parathyroid surgeries performed by each surgeon. Here, we turned our attention to the distance from neighborhoods to the nearest high-volume parathyroid surgeon. The areas in green shown are census tracts that are located within 100 miles of a high-volume parathyroid surgeon, with the orange dots depicting each surgeon, whereas the areas in gray are regions that have limited access to high-volume parathyroid surgeons, which, as you can see, are predominantly located in the central regions of the U.S. We next compared the distance to a high-volume parathyroid surgeon according to neighborhood disadvantage. So as you can see, The distance to the nearest high-volume parathyroid surgeon for the very advantaged group was 8.4 miles, whereas the median distance to the nearest high-volume parathyroid surgeon among the very disadvantaged group was 27.8 miles. So in summary, we found that the majority of high-volume parathyroid surgeons practice in populous metropolitan areas, and we also found significant inequality in the distribution of parathyroidectomies performed by each surgeon. Some regions in the US were largely isolated from high-volume parathyroid surgical care, and as we saw, that was predominantly located in the central portions. And lastly, patients in disadvantaged neighborhoods were much farther from a high-volume parathyroid surgeon than those in advantaged neighborhoods, which may contribute to barriers to equitable access and care among this patient population. So given this data, mitigating disparities in access to high-volume parathyroid care is critical to ensure equitable access to timely, high-quality care. Future efforts to improve patient access to high-volume endocrine surgery include financial incentives to attract providers to areas in need, rural outreach clinics, telemedicine support and financial compensation to ease travel burdens for patients, and academic organizations engaging with surgeons who practice in rural or underserved settings, such that referrals can be directed to a particular surgeon, allowing them to build case volume and expertise. We have several limitations to our analysis, one of which is we were unable to look at the intersection between race, ethnicity, and socioeconomic status due to the nature of our data set. Also, data coming from surgeons, high-volume surgeons who predominantly treat patients who have alternate forms of insurance or treat uninsured patients may not be included in our study. And lastly, given that there's significant heterogeneity in defining high-volume thyroid and parathyroid surgeons within the literature, it's a little unclear what cutoff value for a high-volume parathyroid surgeon is best, but we believe that our cutoff value of 10 parathyroidectomies for fee-for-service beneficiaries in a year, which equates likely to around over 30 parathyroidectomies in total, is both clinically meaningful and supported by prior studies of the volume outcome relationship. So in conclusion, we found that there are disparities in access to high-volume parathyroid surgeons in the US, and patients living in disadvantaged neighborhoods have less access to high-volume parathyroid surgeons, which may adversely affect outcomes among patients with hyperparathyroidism. Future efforts such as rural outreach clinics, telemedicine support, and financial compensation to ease travel burdens are necessary to mitigate disparities in access to high-quality parathyroid surgical care. Thank you so much. Happy to take any questions.
Just as people are coming up to the mic, remember to introduce yourself, your institution, and whether you have any conflicts of interest. Brenessa Lindemann?
Yeah. Hi, Brenessa Lindemann from University of Alabama at Birmingham. No conflicts, but very happy to say that I'm one of the high-volume parathyroid surgeons in Birmingham. So delighted to see that we were number 2 on your map. My question to you, though, relates to this notion of high-volume surgeons, this volume outcome relationship, and the fact that there are disparities to access. Having grown up in a rural area, I can tell you we used to have to drive 3 hours for access to any sort of high-volume provider. And so this may be a challenging question, but how do we navigate this balance of delivering care that is close to people to eliminate these disparities while ensuring that they have the best possible outcomes? Thank you for your thoughts.
Yeah, thank you so much for your question. I think that it's a very good point. I think that there's definitely a balance when we're talking about these sorts of things. And it's important to educate patients on the volume outcome relationship so that if they are able to, they can seek out their care at a high volume parathyroid surgery center. But at the same time, that might not always be possible for patients, and it's really on an individual basis. And the approach that I touched on briefly about engaging academic organizations with these community surgeons who have an interest in endocrine surgery, so referrals are able to be directed to a particular surgeon. I think that could be very beneficial for those patients who aren't able to travel, all of those hours to a center. And eventually, with time, those surgeons could build up their case volume and their expertise, and hopefully that would result in an improvement in patient outcomes as well.
Dr. Beninato, I believe?
Yes. Hi. Tony Beninato, Rutgers University. Congratulations on an excellent study and well-presented paper. I think your data is so interesting because Medicare is kind of theoretically should be an equalizer where people who had all kinds of different insurances when they were younger than 65 now have quote unquote like universal health care or the best that we can offer in this country. But you'll still see that those ingrained habits and the way people interacted with the health system when they had other types of insurance probably still persist once they have Medicare. So I was interested in whether you took a look at the low volume surgeons and the kind of what kind of patients continued to seek them out for their care and predictors of use of those particular surgeons.
Thank you so much for your question. I think it's a great point. Unfortunately, due to the data set that's provided by CMS, it only includes providers that are providing greater than 10 of these procedures. So we weren't unfortunately able to identify those low volume parathyroid surgeons, but I think that would be a very interesting point to study in future investigations.
Thank you.
Dr. Lau?
Victoria Lai, Washington, D.C., no conflicts of interest. Thank you for your study. I was wondering if you would be able to speak to, based on the type of data that you had, and I think we all can agree that we want to increase access to high-volume surgeons, what the data showed with respect to the distribution of endocrinologists. As you know, many patients are not self-referring themselves to surgeons, and there's an intermediary step before they actually get to surgeons. I wonder if you would speak to that if you had that data. I think it would add a lot of nuance.
Yeah, thank you so much for that question. I unfortunately don't have the data on endocrinologists or referral patterns from like the PCP to an endocrinologist to an endocrine surgeon. We were only looking at those based off of the CPT codes, which obviously would not capture endocrinologists that are treating these patients. And I think it brings up a lot of really tough problems with this is already a very complex problem that will be difficult to mitigate, and it's difficult when our ideal audience would be the people who are seeing these patients who are practicing in rural areas and really making sure that they're able to, kind of as we discussed in earlier sessions, provide adequate patient education and ensure that these patients are getting the appropriate follow-up and workup that they need, and encouraging them to seek out care at a high volume center if able. But unfortunately, I don't have data on endocrinologists, but I think that would be very interesting, and that's a very important step kind of in the middle of all this that our study unfortunately doesn't address.
Thank you very much. Unfortunately, we don't have time for the next question. You'll have lots of studies to prepare for the next abstract session.
Thank you.
Next up, we have Stephanie Cisak with senior author Tammy Holm presenting a multi-institutional study for the U.S. ROPE Consortium examining factors associated with endocrine surgery exposure for general surgery residents from the Brigham.
I think we might have the wrong slides up.
Unless you want to talk about the thoracic duct while you're up there.
I do not.
Okay.
You can wing it, right, with no slides?
I could try.
No, they'll get it up.
So injury to the thoracic duct is a dreaded complication of modified radical neck dissection. Dr. Parangi, could you comment on the management in that
We already had that whole discussion. It was previously discussed with that very nice paper. Unfortunately, I can't even see the end of the room because it's like floodlights right into what I thought were clean glasses. But hopefully someone's working on this in the back. Oh, we're getting closer. Nope, Not that. Not that either. Not that.
It's paper 22. I think it may be mislabeled, though.
Nope.
So I wonder if we should go to paper 23 maybe while
And
we're
then
working
we'll
on.
call you back up?
Yeah.
I have a copy of it too.
Okay,
as well, so
we'll
I
call
can
you
bring
back
it.
up.
So we're going to move on for right now to paper 23, malpractice litigation following thyroid surgery. What factors favor surgeons by Joshua Chow, I believe, with senior author Amanda Laird from Rutgers.
Thank you so much. It is my pleasure to be able to present this on behalf of me and my authors. Thank you so much for the moderators and AES for giving us this opportunity. We have no disclosures. Approximately 150,000 thyroidectomies are performed each year in the United States. Litigation comes with heavy costs, and not all of them are simply financial. Thyroid surgery is associated with favorable outcomes, but litigation persists. As far as background goes, medical malpractice is a system that was put in place to incentivize optimal care to patients. This was based on the legal concept of a negligence tort, which is a non-criminal action resulting in money damages. These are the elements that link together the negligence tort. There is a doctor-patient relationship such that there's a duty of care owed, and that duty has been breached, with the breach being the direct cause of a harm, and that harm has to be one that's financially compensable. A patient actually has to prove each one of these elements beyond a 51% chance in order to win. I'll also talk about tort reforms. Tort reforms are changes in laws in response to things like excessive litigation, frivolous lawsuits, high damage awards, with common tort reforms including, oh, that's very nice, including caps on damages, limits to fees, time limits on the patient's ability to sue, and losing party pays winner's fees. Seems only fair.
It looks okay on the screen.
Does it? Okay, they're not seeing all my
No.
secret notes?
No.
Okay, great. Thank you. So, cases begin when a patient files a complaint. There are actually a lot of intervening steps between that and trial and verdict, and at every point in this process, a settlement can occur. It can even occur in the middle of trial. So, there's a lot of scrolling that I'm not doing. Okay, great. Technical difficulties. So, an overwhelming majority of cases settle out of court. And settlement terms often include confidentiality and privacy, so settlements don't really appear in comprehensive legal databases, including the one that we looked at. So in this milieu, we had goals that were twofold. First, what factors are associated with litigation after thyroidectomy? And second, were any of these factors favorable to surgeons? To do so, we took a look at Westlaw, which is a comprehensive collection of legal documents including all published state and federal court cases, extending actually as far back as the mid-19th century. Westlaw does not include information regarding all settled cases, and we used the search terms thyroidectomy and medical malpractice, which yielded a total of 153 cases. 60 of these were excluded because they did not actually involve a thyroid operation or were duplicate cases. Of the 93 that remained, another 25 were excluded because they did not have a final decision. Of the 68 cases that did remain, we broke that up into two cohorts. First, where surgeons prevailed, and second, where plaintiffs prevailed. And data were extracted, including case demographics, operative characteristic, and legal characteristics. Groups were compared, and the primary outcome was the effect on positive outcomes for surgeons. Here, the groups, surgeons and patients, are similar with regard to gender, specialty, and yes. And overall, surgeons won 78% of the cases. There were 3 endocrine fellowship trained surgeons in our data, and it's nice to say all 3 of them won. Cases at academic institutions favored surgeons to a margin of 92 to 71%. Here we show that there were no differences between the 2 groups regarding indication of surgery, type of operation, and post-op complications. The most common complication is recurrent laryngeal nerve injury, followed by parathyroid injury, death, and hematoma. While not statistically significant, it may not be a surprise that plaintiffs tended to prevail more with nerve injury. What may be surprising is when the complication was death, surgeons did better. In both sets of cases, the most common theory of liability was medical negligence, followed by failure to provide adequate informed consent. Juries favored patients. So in the cases that the patients won, 80% of those were decided by juries, whereas only 49% of the cases that were won by surgeon were jury cases, and this was statistically significant. Tort reform favors surgeons. So surgeons practicing in states with tort reforms won at a higher rate with a margin of 88 to 73%. In these data, there is a statistically significant increase in cases per decade. And while plaintiffs won in a minority of the cases, when they did, the damages were significant at a median of $570,000 with a range between $340,000 and $2.6 million. An overwhelming number of us will have been sued at least once before we turn 65. However, fortunately, surgeons win a large majority of those cases. Most cases don't even reach the level of court or trial or motion, any of these things, because they settle. And while it may not feel that way, a settlement is not a win by a patient. We also know that tort reform has critically important effects, including reducing litigation volume. So here we took all medical malpractice payments per year, broke them up by state, and then per state, per capita. And for example, in states where there was no tort reform, such as New York and Pennsylvania, their per capita payouts could be as much as 6 times that of states where there are healthy tort reforms in position, such as Texas and California. We do have limitations to this study. It is retrospective. The quality of the data is affected by the non-medical expert sources. Private settlements, how most cases are resolved, were not available, as the medical records were also unavailable. So we see in the study that litigation in thyroid surgery is infrequent, with few awards to patients. Surgeons appear to have the favor of courts, but do comparatively poorly with juries, and tort reforms appear to favor surgeons. Thank you so much. I'm happy to take any questions.
Dr. Sipperstein.
Alan Sipperstein, Cleveland, no conflicts. Having served on our medical legal committee for a decade, I am unfortunately way too familiar with this whole area. And medical centers will only go to court if they feel that they can win. And the vast majority of cases are settled. What's fascinating about your data has to do with the areas of which suits are filed. That is death, hematoma, nerve injury. And I'm wondering if you have any perspective or can get any perspective on the vast majority of cases that are settled.
That's a great question, and thank you for it. So in our data set, there were no settlement data. The difficulty with data sources is that a lot of the settlements actually have clauses in them to keep them private and confidential. It's a settlement term that they never get public, and it's an agreement between private parties. So it ends up being a little nuanced to be able to get our hands on that data. We are talking with Rutgers Legal Counsel and hoping to interface with some of the malpractice insurance payors to see if we can expand our perspective on that.
I can't quite see who's at the back there.
Mahsa Javed, University of Louisville. This might sound like a bit of an odd question in a room full of surgeons, but we are also patient advocates. I recognize that you don't have the medical records, but can you give us any insight into how we can actually promote patient advocacy in cases where they deserve to win?
Thank you for that question. I think it ends up being cats versus dogs, and we're so often, I don't know, cat or dog, but we're so at odds with our legal counterparts that it is difficult to almost bid against ourselves and say, we've made a terrible mistake here, you deserve compensation. And I don't think that's anything that we would ever do. And even if I were to do that, my risk management department would, I think, probably kill me. So it is a delicate balance because really this is not supposed to be a punitive system. Really it is a system that creates certain penalties to help promote optimal care. And I wonder, great question, thank you.
I'm being told by leadership we have limited time, so just a brief question.
Yes, I share the same responsibility Dr. Sipperstein had. I'm Sam Snyder from Edinburgh, Texas for DHR UTRGV. And we settled most of the cases. We tried to, and the only ones we took to jury is the ones that we thought we could win. You noticed that nerve injury was #1 for the patient. So could you break it down into unilateral versus bilateral injuries, tracheostomy, or whether or not patients had nerve monitoring? Those are big questions.
Sure. And our data is limited just to non-medical records. However, to answer your first question, or third question first, there was only one case in our whole data set that mentioned the use of nerve monitoring. It does not seem like it's an issue that's yet been picked up by our lawyer counterparts. And I think that we would assume that a case where a tracheostomy was necessary would be one that was won or lost, probably lost by the surgeon. But the way that representation works, if you have a more quality attorney, you, I guess, get away with more. So the facts didn't quite align with the results necessarily, because it was in my first day of torts course that I heard that the law and ethics are very different things. They're two separate worlds, so thank you.
Thank you
That's
very
the real
much.
world.
While Stephanie's coming up, I'll say it was interesting visiting New Zealand a few years ago, where surgical bad outcomes are considered accidents, much like you breaking your leg on an escalator in a mall or something. They're all along the same spectrum and fully covered by accident insurance, which I thought was interesting.
All right, hello, second time's the charm. My name is Stephanie Sisak. The authors have no disclosures. So there's an increasing amount of endocrine surgery cases that is being performed in the United States. The creation of additional endocrine surgery fellowships will meet some of this demand. However, the volume of endocrine surgery surpasses the number of fellowship-trained endocrine surgeons. Endocrine surgery is performed by general surgeons, otolaryngologists, surgical oncologists, and fellowship-trained endocrine surgeons, and the training and recruitment of all of these types of surgeons may help meet some of this demand. However, as we all know, the changing landscape of general surgery residency has called into question the ability of general surgery residents to perform these cases upon graduation without additional training. So in this study, we sought to identify factors that affect the endocrine surgery experience of general surgery residents, as well as understand the differences in those who choose to pursue an endocrine surgery fellowship and match versus those who do not. This information will hopefully allow us to better understand how to both encourage further pursuit of the field, as well as prepare those who do not pursue a fellowship to perform these cases. The bottom line is that there aren't enough surgeons to go around, so we need to train more endocrine surgeons regardless of the path that they take into practice. So this study was a retrospective cohort study that utilized the ROPE Consortium. This is a consortium of 18 ACGME accredited general surgery residency programs who pooled their graduate case log data from 2010 to 2020 in order to analyze the recent resident operative experience. There were 1,240 residents included in this study. This is a map depicting the names and locations of the participating programs. So we supplemented the database of graduate case log information with a survey distributed to the participating programs. Some of the questions that we sent in the survey are listed on the right and essentially focus in on endocrine-specific program characteristics. This includes the type of faculty that are employed, as well as questions regarding the general surgery residency curriculum. So in order to evaluate AIM-1 and kind of understand the individual and program-specific factors that affect the total number of endocrine cases performed by general surgery residents, we performed a multivariate analysis. So on this table, our intercept is considered the average resident, and for our purposes, we set this as a white male resident from a small size, low volume program with no additional endocrine-specific characteristics. I think what's really striking about this slide is one, female sex did not affect the total number of endocrine cases performed, but race and ethnicity did. So Black residents performed 5 less cases, while Asian residents performed 4 more cases. This information correlates with another recently published study out of the ROPE Consortium, which showed that Black residents perform less total general surgery cases upon graduation. So this study proves that this disparity is prevalent even in endocrine surgery. So when we specifically are looking at the endocrine-specific program factors, you can see that a lot of them affect the total number of endocrine cases performed by general surgery residents. Again, the intercept here is the average resident. So I think what's most striking about this is that an endocrine surgeon as faculty and an endocrine surgery-specific rotation in the general surgery residency curriculum have the largest increase in the number of cases that residents perform. When I say like an endocrine surgery specific rotation, I mean that it is a separate rotation and it is not rolled into surgical oncology, breast, et cetera. I think it's also interesting to note on this slide the relationship with ENTs. So a dedicated endocrine ENT as faculty decreases the number of cases performed by residents, but an associated ENT residency increases the number of cases. This is very interesting to me. I think likely this means that a ENT residency, you're associated with a larger academic center, you have a larger referral base, and that means more cases for all types of surgeons. However, a dedicated endocrine ENT may directly compete with an endocrine surgeon as faculty. And for the purposes of this study, we defined a dedicated endocrine ENT as someone whose practice is comprised of greater than 50% thyroid and parathyroid. So when we specifically looked at the residents who matched into an endocrine surgery fellowship, we found that 17 of our cohort matched. And this may seem like a very small number, but it actually correlates with the national match, which was at 1.9% for this same time period. And there were no differences in demographics when compared to other residents in the cohort. So this is really striking to me. The residents who matched performed more total endocrine cases, as well as more cases in all domains of endocrine surgery. So that includes thyroid, parathyroid, and adrenal. This really highlights the idea of early specialization among general surgery residency. It is unclear whether these residents perform more cases and then choose to pursue a fellowship, or if they choose to pursue a fellowship and then perform more cases to better prepare themselves. But at the end of the day, it is clear that a general surgery resident who does not match into endocrine surgery is performing way less cases. There were no differences in the non-endocrine program characteristics among residents who matched into fellowship versus the remaining cohort. And there were also no differences in the type of faculty employed, which included endocrine surgeons, endocrine-focused general surgeons, and endocrine-focused ENTs. And there was also no difference in the association with an endocrine surgery fellowship. Where we start to see differences is in the previous successful placement of a graduate into an endocrine surgery fellowship, as well as an endocrine surgery specific rotation in their curriculum. The previous placement of a graduate obviously means that there's an established pipeline with established mentorship, networking, and research opportunities. And I think that one of the most important things to come out of this project from my standpoint is that an endocrine surgery rotation really affects the endocrine surgery experience of general surgery graduates. An endocrine surgery rotation was associated with residents pursuing a fellowship, and it was also one of the factors that greatly increased the number of total endocrine cases performed by all general surgery residents. So in conclusion, disparities exist in the endocrine case volume performed by these residents. Residents who match perform more cases and graduate from programs who either previously placed a resident in fellowship or with an endocrine rotation in the curriculum. And recruiting dedicated endocrine surgeons and creating endocrine rotations is what is going to improve the overall resident experience, which is particularly important for general surgeons who may go straight into practice in a rural or broad-based practice and will be performing endocrine surgery without a fellowship training. Thank you, and I'd like to take this moment both to thank the AES and the ROTE Consortium. These collaborators are listed here.
So just while people are coming to the mic, I had a brief question. Did you guys have any data on timing of the rotation as it impacts the decision to pursue an endocrine fellowship?
No, we do not. I think it's very interesting because I was recently talking with some of the collaborators that it widely varies when there's an endocrine rotation. I mean, interns to chiefs are performing these cases. There's not a really good, I think everybody has their own personal opinion on what sort of level resident can perform these cases, but no, we do not have any information on timing.
Dr. Russell?
Thank you. John Russell, Baltimore, head and neck endocrine surgeon. How do we change that? Fantastic job presentating, good word. This is why you don't work with otolaryngologists, right? We can't even make up words. How do we change that? It was interesting that you found that if there's an otolaryngology program, that it actually has a positive impact. If there's a focused head and neck endocrine surgeon, it has a negative impact. What do we do to collaborate better so that that's actually a synergistic effect and actually amplifies it for both groups of training?
Yeah, I think that's really interesting, and I think one of the ideas that I was kind of kicking around in my head is for programs that don't have endocrine rotations, you can create, and maybe a smaller program or is not associated with a larger academic center, you can create endocrine rotations where these residents are sort of shared between otolaryngologists and dedicated endocrine surgeons. And I think that might twofold help kind of provide more cases for all of the residents, as well as kind of mitigate or sort of create endocrine surgery rotations to help get people more cases. I think that in general, I think just open communication and sort of discussing what's going on and kind of not making it a contradictory or sort of negative collaboration is the way to go.
Dr. Krishnamurthy?
Hi, Vikram Krishnamurthy, Cleveland, Ohio. Great presentation. A similar question, or at least related. Did you have any information on having an endocrine-focused general surgeon, if that negatively affected the case volume of the ENT residents? Thank you.
The question was, an endocrine-focused general surgeon negatively affecting?
Well, did it affect the volume of, did you look at if it affected the volume of the otolaryngology residents?
It did not affect the volume of the total endocrine cases that are being performed. Yes, did that answer your question?
By the otolaryngology residents or all residents?
Oh, sorry. We do not have the case log data for otolaryngology residents, which is one of the limitations of this study, is that we only had general surgery graduates. So I think my next steps is getting the otolaryngology case log data and seeing, I don't know exactly how they log it, and learning how they log their cases. We do not have any information on if the opposite is true, i.e. if a general surgeon is taking cases away from ENT residents.
Yeah, great presentation.
Thank you.
At the front here.
Hi, Polina Zhemievsky, UAB, no conflicts of interest. So I do a little bit of work in case logs myself. A common criticism of my work is, does 5 cases, as far as disparities between groups of residents, really matter? And what I would say is, I think that maybe 5 cases here or there doesn't, but the trend itself is very troubling. And my question to you is, do you have any hypothesis as to why that disparity seems to exist?
Mm-hmm. I do. So I think that there is a lack of networking and mentorship opportunities in endocrine surgery for Black residents, but I think that the reason is because, one of the most interesting talks that I heard at APDS about mentorship was the best mentors are people who are different from yourself and people who look differently. So I think that this disparity exists. It's prevalent in all of general surgery residency for all cases, and then it's prevalent in endocrine surgery, and I think that is the main reason, is lack of mentorship. So I think that one of the ways to change that is for everybody who has the ability to be a mentor to look for people who are different races, different socioeconomic backgrounds, and sort of all you really need is a passion for endocrine surgery. And so to kind of look to build those relationships.
Thank you.
Thank you.
Then we have time for one more question.
Abby Fingerett, University of Nebraska, no disclosures. Thank you for an excellent presentation. Not surprisingly, you found that those that matched into endocrine surgery fellowships had higher case exposure to endocrine cases. In your survey of the ROPE programs, did you ask specifically if they had elective opportunities for their residents? And is that case discrepancy because those residents chose to do an elective in their future specialty?
Yeah, thank you for your comment. We did not specifically ask if they were elective rotations, but from my own kind of experience in talking to people, I think that that is likely the case. Obviously, the general surgery residency curriculum is very tight with not a lot of movement because we need to get specific case numbers for multiple domains of general surgery. So I think that likely what occurred, because 44 cases is a pretty large number for differences in case numbers. So I think likely what would occur is doing either an away rotation or some other elective rotation or re-rotating as well.
Thank you.
Thank you.
Thank you so much.
Thank you.
Next up, Leah Hendrick with senior author Olivia DeLazier will be presenting lithium-associated primary hyperparathyroidism, an evaluation of screening and referral patterns in a southeastern veteran population from the University of Tennessee.
Good afternoon. Thank you for the opportunity to share our work. We have no disclosures. It's been established that primary hyperparathyroidism is underdiagnosed and undertreated. Although the classic findings of fractures, nephrolithiasis, and psychiatric symptoms are well established, many patients with mild or asymptomatic disease will benefit from parathyroidectomy. For this reason, it's important to maintain a high index of suspicion in patient populations with elevated risk of disease. Lithium therapy, commonly used to treat patients with bipolar disorder and other psychiatric illnesses, has a clear association with hyperparathyroidism, with a 10 times increased incidence of hypercalcemia demonstrated consistently in the literature. Since symptoms of hyperparathyroidism and bipolar disorder have some overlap, it may be difficult for clinicians to differentiate worsening of pre-existing mental illness and adverse effects from lithium-associated hyperparathyroidism in these patients. We hypothesize that rates of screening in patients undergoing chronic lithium therapy and referral for subsequent parathyroidectomy are suboptimal. Our primary objective for this study was to evaluate rates of hypercalcemia, screening for hyperparathyroidism, and referral patterns for endocrinology evaluation, as well as for parathyroidectomy among U.S. veterans on chronic lithium therapy. Our secondary goal was to describe outcomes and rates of biochemical cure for patients with lithium-associated hyperparathyroidism who underwent parathyroidectomy. We performed a retrospective cohort study, including all veterans treated with chronic lithium therapy at the Memphis VA Medical Center over a 23-year period, with chronic lithium therapy defined as at least 12 consecutive months of treatment. Data were abstracted from the corporate data warehouse for the Memphis VA, and variables of interest included baseline demographics, serum calcium levels before and during lithium therapy, as well as the most recent available serum calcium. PTH levels were recorded when available, and patients with stage 3 or higher chronic kidney disease were excluded. For hypercalcemic patients with elevated PTH, evaluation of bone mineral density as well as nephrolithiasis were recorded, and referral to endocrinology or endocrine surgery was noted, as well as outcomes following parathyroidectomy. Baseline characteristics between hypercalcemic and normocalcemic patients on chronic lithium therapy were compared using standard statistical methods. All continuous variables were reported as median with range, and qualitative data were critically reviewed by 2 independent investigators to exclude other etiologies of hypercalcemia, such as malignancy and granulomatous disease. Of 514 patients on chronic lithium therapy, the median age was 61 years, and 84% were male. The majority of the cohort was white, with just over a quarter Black, 11% Hispanic, and 1.4% Asian. The median duration of lithium therapy was 2.5 years. 148 of these patients, or 28.8%, were hypercalcemic. This table compares baseline characteristics of hypercalcemic and normocalcemic patients on chronic lithium therapy. There was no difference in age, sex, ethnicity, or race between groups. Hypercalcemic patients had a significantly longer duration of lithium therapy compared to normal calcemic patients, with a median of just under 5 years in the hypercalcemic group compared to just over 2 years in the normal calcemic group. 148 patients had calcium levels of 10.2 or greater, raising suspicion for possible hyperparathyroidism, with 3/4 of these patients undergoing no further testing after that point. Of the 36 hypercalcemic patients with an available PTH recorded, 92% had PTH greater than or equal to 30. 10 of those patients, or less than a third, were referred for evaluation by an endocrinologist, and ultimately, surgeons in the VA system saw 5 of those patients. Shown here are the characteristics of the 33 patients with suspected hyperparathyroidism. Median serum calcium prior to initiation of lithium therapy was 9.6, compared to 10.8 after at least 12 months of treatment. This was a significant difference. Median PTH was 67. Just over a third underwent evaluation of bone mineral density with a median T-score consistent with osteopenia. Nearly 2/3 of patients were evaluated for nephrolithiasis with imaging, and 1/4 of those studies were positive. We then looked at the association between the duration of lithium therapy and incidence of hypercalcemia. In patients undergoing treatment for under 5 years, the incidence of hypercalcemia was 23%. With increased duration of therapy up to 10 years, this incidence increased to 44%. And then in patients on more than 10 years of continuous lithium therapy, the incidence of hypercalcemia increased to nearly 75%. Of the 5 patients who were referred for surgical evaluation, 1 declined surgery and 4 underwent parathyroidectomy. Patients 1 and 2 underwent unilateral exploration with single-gland parathyroidectomy, both with initial biochemical cure. However, patient 1 had recurrence at just over 2.5 years. Patient 3 underwent bilateral exploration with intra-op PTH measurement, 2-gland parathyroidectomy, and experienced persistence despite re-exploration several years later and removal of an additional gland. Patient 4 underwent bilateral exploration with intra-op PTH measurement, 3-gland parathyroidectomy, and evidence of biochemical cure at 8 months postoperatively at this point. This table highlights the major previous studies evaluating parathyroidectomy in patients with lithium-associated hyperparathyroidism. Several studies report high incidence of multi-gland disease, with recommendations for bilateral exploration and rates of biochemical cure between 73% and 100%, with wide-ranging incidence of recurrence up to 33% in some studies. Although the current study involves very few patients who ultimately underwent parathyroidectomy, these outcomes do align with the reported literature, with a reported biochemical cure rate of 75% and a recurrence rate of 25%. We acknowledge several limitations of this study. First, as is common in VA-based studies, the majority of our cohort is male. As we know that hyperparathyroidism is more common in women, these data may not accurately represent the true incidence of disease. Additionally, our data does not capture patients referred outside the VA system for care, and therefore the referral rate for patients with lithium-associated hyperparathyroidism might actually be higher than what's reported. Duration of lithium therapy in this cohort was wide-ranging from 1 year to over 10 years. And although we've established that there's an increased rate of hypercalcemia the longer patients are on lithium therapy, it's unclear if there is a cut point with either duration or dosing, at which point these patients are at higher risk. And finally, we were unable to capture rates of resolution of hypercalcemia after cessation of lithium therapy in our cohort. So in conclusion, screening, surveillance, and surgical referral in patients with hyperparathyroidism is underutilized in U.S. veterans on chronic lithium therapy. These findings suggest that more than 25% of patients on chronic lithium therapy will develop hypercalcemia, many of whom are suspected to have hyperparathyroidism. Longer duration of lithium therapy is associated with higher likelihood of hypercalcemia and suspected hyperparathyroidism. And finally, the study demonstrates that institutional protocols are needed to standardize screening and appropriate referral in at-risk patient populations such as these undergoing chronic lithium therapy. I would like to acknowledge my co-authors, and I'm happy to take any questions.
Excellent job. Maybe I'll just ask a quick question while people are coming to the podium. So, did you study at all whether there were referrals from nephrologists? Because I find, at least in my practice, a lot of times once there's renal damage, there seems to be more interest in referring the patient. And I hope your patient with the calcium of 13.9 and the PTH of 622 got surgery.
They did. They were one of the 4. Thank you, Dr. Parangi, for the question. We looked individually at these 33 patients with suspected hyperparathyroidism. We went through all of the charts together, and there were no referrals there from nephrology. They all came from endocrinology.
At the back.
Brad Mitchell, Dover, Delaware. Thank you very much for the interesting presentation. I'm working on a presentation with a psychiatrist at my hospital, and we've come up with the term of permission to ignore. That is, permission to ignore symptoms that are neuropsychiatric, or permission to ignore mild elevations in calciums. And I think your data points that out, that these patients aren't getting worked up when they should be. It looked like some of your patients were hypercalcemic prior to lithium therapy. And I wonder if you look to see if any of their neuropsychiatric symptoms resolved after parathyroidectomy.
Thank you for your question. It was really interesting to look at these patients, and clearly with some overlap in symptoms between hyperparathyroidism and patients who warrant lithium therapy. It's a challenging paradigm. Unfortunately, our number of patients with who ultimately underwent surgery was really too low to draw any lasting conclusions about cure or about resolution of symptoms, and that's unfortunate because it's very interesting, and we hope in the future with some prospective data collection to be able to more clearly answer that question.
Dr. McHenry.
I just had Chris McHenry from Cleveland, Ohio, of No Disclosures. Just the thing I learned from your presentation is that you've documented a really high incidence of lithium-associated hypercalcemia, hyperparathyroidism just by your screening, 29%. And I've not seen that figure before, and that's very high. But I think one of the important things to emphasize is that discontinuation of the lithium will cause or will result in resolution of hyperparathyroidism in most patients when it's recognized early. And in the past, there was a reluctance to really stop the lithium because there weren't good alternative therapies for bipolar disorder, which there are now. But I think that's an important thing, and much of your data here, and not knowing which patients actually got their lithium started, that may be a significant confounder in your data, and I wondered if you might comment on that. Yeah.
Thank you for your question. We do acknowledge that, and we hope in the future to be able to delineate that. We worked closely with one of our pharmacists at the VA to try to delineate the timing of cessation of therapy in hopes to have that data, but we just weren't able to do it with any reliability. We did look at the most recent calcium available for this cohort of patients, and these patients were still hypercalcemic at a rate of 60% at the most recent check, which for some patients clearly is over 20 years, given the span of our study.
Dr. Saunders, whose conflict of interest is his wife is the chair of psychiatry at Penn State. Go ahead.
Yeah, Brian Saunders, Penn State. No conflicts outside of my marital relationship to a bipolar disorder specialist who uses lithium all the time. So I guess I think the data that you show is very educational and should likely be shared outside of this audience, certainly, that is already biased towards operating on these folks. And I think it speaks to the need for guideline-directed care in psychiatry as well as other areas. So what frequency would you suggest that they do their screening? Because lithium has other endocrine complications, not just parathyroid, obviously. but renal as well. Because especially in this VA population, where finances are often an issue, lithium is one of the less expensive but most effective mood stabilizers. So I think there is and likely should be a reluctance to discontinue that medication when there are treatable and manageable complications. Thank you for your presentation.
Thank you for your comment and question. Our goal with a paper like this is that it'll give us some concrete data to go back to our colleagues in the field of psychiatry as well as our primary care colleagues and have a conversation about referral patterns, screening, as well as there was a study yesterday presented from a VA population about primary aldosteronism looking at institutionalized screening and potentially even using the EMR to help screen these patients better. And so we would love to see something like that implemented in our institution down the road as we begin conversations with our colleagues from other specialties. But regarding frequency of screening, I think ultimately that's up to the PCPs, but I would be comfortable seeing them screened every 6 months or so to make sure that we're not missing anything.
Thank you very much.
Thank you so much. Excellent presentation.
And last up, we have Catherine Bogg with senior author Kimberly Reminell from the University of Pittsburgh presenting on gender differences in patients with primary hyperparathyroidism.
Well, good afternoon. I'm Catherine Baugh. I'm the current Endocrine Surgery Fellow at the University of Pittsburgh. Thank you for the privilege of the podium. Today I'll be presenting our study entitled Gender Differences in Patients with Primary Hyperparathyroidism. And we have nothing to disclose. So primary hyperparathyroidism is caused by inappropriately elevated production of PTH in relation to serum calcium. It occurs in 0.1 to 0.5% of the population and leads from anywhere from 9 to 17,000 parathyroidectomies a year in the US. It's more common in females, with the female to male ratio of 3 to 5 to 1. And as recognition grew that curative surgery led to improvements in quality of life, methods to assess severity of symptoms and response to surgery also came into use. So in 1998, the PASICA parathyroidectomy assessment score, commonly known as the PAS, was introduced, in which patients use a visual analog scale in order to self-report severity of 13 commonly experienced symptoms. Patients rate each symptom on a scale from 0 to 100, with increasing severity as the scale gets higher. Now, the individual and cumulative scores are then compared pre- and post-surgery to assess response to surgery. So this is a copy of the PAS questionnaire that we give patients. We began routinely giving this questionnaire in 2010, and the questionnaire is given to patients at their initial clinic evaluation, 2 weeks after surgery, and then again at 6 months. And you can see the 13 different parameters. Now, we also include a generic quality of life and wellness self-assessment, where patients rank themselves from 0 to 10, with 0 being the worst quality of life or wellness imagined, to 10, which is the best possible. And so we sought to examine the validity of the PAS in a contemporary cohort of primary hyperparathyroid patients following curative parathyroid exploration, and also to compare PAS outcomes between genders. We retrospectively reviewed all patient data for patients with primary hyperparathyroidism who underwent parathyroid exploration, and this was pre-COVID, so this was from January 2016 to December 2019. Again, we have patients fill out the questionnaire at their initial clinic visit, 2 weeks post-op, and then again at 6 months. Each patient was reviewed, and the individual and cumulative PAS was calculated. So just going through our exclusion criteria, during that time period, there are 1,300 patients who underwent parathyroid exploration. Patients were included if they had primary hyperparathyroidism, if it was the index operation, and if they had cure determined by normal calcemia at 6 months. Questionnaires were then screened for completeness and were included if both a pre- and a post-operative questionnaire were available. So in total, we had 701 patients included in the study, and out of that 701 patients, 400 patients completed questionnaires at all 3 time points, 226 patients completed a pre- and a post-operative questionnaire, and 75 patients completed a pre- and a 6-month questionnaire. So in looking at the outcomes of the whole group, we see that the median PAS score was 140 at the pre-op evaluation, which decreased by 36% to 90 at the first post-op visit. The score continued to decrease to 70 at the 6-month evaluation. However, the change from the initial post-op visit to 6 months was not significant. And when comparing by gender, there was no difference between age, race, or BMI. Males did have a slightly higher mean preoperative serum calcium level, but PTH was equivalent. Males were asymptomatic more frequently, as defined by a PAS score of 0. And in terms of classic symptoms, males were more likely to have kidney stones than females at 38%, but females had a higher incidence of bone demineralization at 51%. Now, when you subdivide by gender, we found that the preoperative median PAS in females was 155. Median scores decreased by 35% to 100 at the initial post-op visit, and then decreased by 48% to 80 at the 6-month visit. And when examining males, we saw a median pre-op PAS value of 80.5. Post-op median PAS decreased by only 13% to 70, and by 29% to 57.5 at 6 months. When you look at them side by side, you can see that females report a significantly higher PAS score pre-op and at the initial post-op visit, but by 6 months, their scores are largely equivalent. In terms of the individual PAS parameters, pre-op females had significantly higher reported severity in 11 of 13 parameters, which included everything but feeling weak and difficulty getting out of a car or a chair. Therefore, they reported greater symptom burden in 11 of 13 areas. By the post-op visit, females only reported higher scores in 5 of 13 parameters compared to the males. And by 6 months, there was no difference. And briefly, despite difference in severity of symptoms, there was no difference between quality of life and self-assessed wellness between the genders at any time point. So lastly, our study did have multiple limitations. It was a retrospective review of a single institution. However, this represents the largest study of the PAS to date. There was a much lower number of male patients. However, the ratio is pretty classic for the disease process. And we also excluded patients that did not have cure or that had reoperations. We excluded patients that did not fill out the questionnaire, so this could lead to potential bias. However, the ratio of males to females was equivalent between the responders and non-responders, and preoperative serum calcium was actually slightly lower in the non-responder group. And so one of the interesting findings of the study is that our median pre-op PAS was lower than previous reports. In the initial studies by Dr. Pasica, they reported a median score of 282 in their US population and a median score of 344 in the Canadian population. In 2008, Mahai published a study with a median score of 460 in the UK population. And in 2019, Svensson reported a lower PAS of 225. And this is compared to our median PAS of 140. And so what we're noticing is that there is a trend towards lower preoperative PAS scores, and that this could be a reflection of improved screening through routine chemistry evaluation. And so all in all, we may be diagnosing primary hyperparathyroidism at an earlier and less symptomatic stage. So when you examine scores based upon gender, both males and females do show improvement in cumulative and individual PAS after parathyroid exploration, demonstrating that both experience symptom improvement after surgery, and thus both benefit from surgery. However, there are disparities. Males report a much lower PAS or are less symptomatic at presentation, with minimal change or improvement in symptoms after surgery. So the question now is, do we need further studies evaluating new quality of life metrics to address current cultural and gender differences in a modern, less symptomatic population? Okay, well, thank you so much for your attention. I'll take any questions.
Thank you for that excellent presentation. As people come up, I'll just mention that the year I graduated from residency, I do remember Dr. Pasica presenting her PAS and the construction of
from high school?
Oh, here we go. Yeah, from high school. Thank you, Janice. Yes, I was very interested in endocrine surgery in high school. And I was going to ask Dr. Pasica to come up and comment. Here she is.
Thank you very much, and what a wonderful presentation. I really want to thank the Pittsburgh group for taking this and really running with it. And I think that should be a reflection to all of you in the audience. This was something I presented here, and how we network and how we then can share our ideas and things across continents, and it's just wonderful. So thank you to the Pittsburgh group for doing this. I was going to come up and make a smart remark that maybe men just aren't as sensitive to their bodies, but I can't do that. Don't record that. No. I do have one no, okay. So the PAS score was based as a disease-specific tool, meaning that it would measure meaningful change, and that means it has to have some impact on the patient themselves. So I was very curious to see that unlike the original studies where we demonstrated that that change that we saw in the PAS score was reflected in an improvement in their quality of life and their wellness, you didn't find that. So does that mean it's not meaningful anymore to the patients, or are you thinking that this is they're not as symptomatic as they were back when Dr. Parangi was in high school?
Well, thank you so much. Thank you for your question. No, absolutely, I do agree. I think the reason why it's not affecting their quality of life and their overall self-assessed wellness is because we're detecting it at a much earlier stage, so they're much less symptomatic. And that's what's reflected in the data. The PAS score, the median PAS scores were much lower than previously reported. And so I don't think they're as symptomatic, and so they're less affected.
Yeah, so I think it is time, your last point, it is time to come up and revalidate a meaningful tool to our patient population. But thank you again.
Thank you.
Thanks, Janice. Dr. Elfenbein?
Yeah, Dawn Elfenbein from Wisconsin. Dr. Pasika, forgive me for not knowing your original data, ma'am, but I was going to ma'am you again. What was this study, or is it time to do this again? If it was done originally, is give this survey to people who don't have primary hyperparathyroidism. I find my patients go through that and they say, well, I have this, I feel it, but is it due to something else? You know, I just don't know where the number is for people who are controls, essentially.
No, absolutely, that's a good point. I mean, I frequently joke to my colleagues that my PAS on a daily basis is probably 100. We're all fatigued as surgeons, so I think that's a good point.
Can I ask a quick question? Your quality of life measure, was it a single question?
Yes.
So can I just ask, from a methodology standpoint, there's validated quality of life tools that you could use. And so I just wonder, why did you not use one of the validated tools in quality of life? There's even thyroid, that Dr. Grogan has developed a tool that could be used for that. So what was the reason?
Oh, no, that's a very good point. And then that is something we are looking at now, is to changing our quality of life measures. Previously, this was just attached to the end of the PAS questionnaire when it first came out, and it's just been continually reiterated.
Right, so I guess I would just caution the conclusion that this does not impact quality of life when it hasn't been actually studied in a thorough way.
Well, I'd just like to point out that that single quality of life is a validated tool, and it was compared to the SF-36 as an overall global quality of life, and it has been validated. But I really think it's time, because we have more specific quality of life tools, to redo this.
I guess I'll just ask one last question. How do you get all the patients to fill out those level of surveys? I mean, honestly, kudos to you and your team. Congratulations on a great talk.
Oh, thank you.